Hello everybody and welcome to Emergency Medicine Quest. In this video we are going to talk about thermal burns. Burns in general are a common ED presentation. Thermal injuries are different from mechanical injuries such that damage tends to be dynamic and tends to progress over time. So just some brush up on the skin anatomy. There are three skin layers. So we have epidermis, we have dermis, and we have the subcutaneous layer. Epidermis is what provides the waterproofing and bacteria proofing, whereas dermis gives the skin its toughness and durability. Dermis is also where the epidermis regenerates from in cases of thermal injuries and is an important source of stem cells. Regarding the pathophysiology of the burn, so any temperature less than 44 degrees Celsius is well tolerated and it does not cause any injury even after prolonged exposure to this temperature. But temperatures more than 60 degrees Celsius, they can cause cell injury, they can cause protein denaturation in the tissues. Burns in the literature actually described quite similar to stroke and heart attack in the sense that large number of cells and tissues get destroyed at the same time. In Rosen's, there are three zones of burns that are described. So they say that the central zone is the area of irreversible necrosis. After that, they have an area of stasis. And finally, the last zone is actually area of inflammation. Now let's talk about the classification of burn injuries and why it is important. So the reason why it's important to classify accurately as much as we can is because it is what our management and prognosis is dependent on. So we have 4 degrees of burns that we are going to discuss, starting from the first degree of burns. So the first degree of burn basically corresponds to burning of the epidermis. We notice that there is no blister formation in this. So there's just going to be some mild erythema around the burn place. And we notice that it's quite painful and it heals in 1 week. The second degree of burn can be divided into superficial and deep. So superficial partial and deep partial, although both of them affect the dermis, superficial partial affects the papillary dermis. There are presence of blisters, it is quite painful and it heals in 2 to 3 weeks. The second degree deep partial burns, we see that there is presence of hemorrhagic blisters. It is also quite painful and it affects significant portion of the dermis, and we see that usually these wounds are either white or mildly erythematous. Normally these heal in 3+ weeks, or the prognosis can also progress to a third degree burn. In children, this burn can also cause significant scarring and contractures. Third degree burns are called the full degree burns, full thickness burns. So they are quite dry, so we will not see blisters. They are leathery, the skin is quite stiff. They involve the full layer of dermis, and usually it requires surgical excision plus or minus grafting. Fourth degree burn is basically involving till muscle and or bone. So we will see that the appearance of these wounds, they are quite brown, they are quite charred, they're also very dry. We'll not see any blisters, and usually this degree of burn leads to loss if it happens in the limb, for example. So there's going to be a loss of the limb because of the burn. So we have something called as box score. Basically, this is the sum of patient's age plus the percentage of total body surface area that is burnt. As per the literature, a score of more than 160 predicts about 100% mortality. Now, how do we calculate the total burn surface area? So, one of the way that we can do it is through Wallace rule of 9, which is applicable for adults. So, burn of head and neck is about 9% burn. Burn of chest is 9%. Burn of torso of abdomen is 9%. Burn of genital area is 11%. And burn of each lower extremity is about 18%. So 9 and 9. Burn of each hand is 9%, and the burn of palm is 1%. In children, we use a similar chart, but it has been modified for pediatric age use, called Lund-Browder chart. So how do we classify how severe the burn is? So if we talk about children, anything less than 5% of total body surface area that is burned is mild, and more than 10 is severe. So it's the same for children and elderly. So 5 to 10, more less than 5 is mild, more than 10 is severe, and 5 to 10 is moderate. And for adult, it's about 10 to 20. The implication of this classification is in the management. So if they come with mild burn, then we are going to manage them on an outpatient basis. If they come with moderate burn, then we are going to admit them. And if they come with severe burn, then we are going to transfer them to a burn center. Management of patients with thermal injuries. So let's first talk about the first aid component. Some of the principles of first aid are ABCs, as it is, always. Then remember to remove the patient from the source of injury, remove the garment, remove any jewelry. Do not run the burn area under ice cold water because that can cause frostbite. So always use under room temperature water. In the ED, blisters should be left intact. Have 2 large-bore IV cannulas, especially in patients who have widespread burns or large burns or higher degree burns. Appropriate pain management and avoid hypothermia. In the ED, the first thing from the ABCs is airway management. So before we jump into how we manage, let's first understand what are the signs of upper airway injury and lower airway injury. Obviously, this is not very specific, but it's something that can be used. So upper airway injury is things like charring, soot in the mouth, mucosal inflammation or necrosis, and edema. In case of lower airway injuries, we have wheezing, CREPS, ARDS manifestations, hypoxemia. Classically, what has been taught is that facial burns, any nasal hair if they are burned, carbonaceous sputum or history of burn in enclosed space, that these are very specific for airway injuries, but recently studies have found that these are neither specific nor sensitive, so it must be used with caution. The true diagnosis of any airway injury is obviously visualization under fibroscopy. If you can see any of these signs directly, then that is a true diagnosis. Now, what are the indications of intubation for burn patients? So we have 6 criteria. If we notice that the patient has upper airway obstruction, patient is unable to handle secretions, hypoxemia despite 100% oxygen, if the patient is obtunded, muscle fatigue, and this is basically seen by the respiratory rate if it's too high or too low, and finally hypoventilation if the PCO2 is more than 50 and the pH is less than 7.2. Regarding breathing, so we need to make sure that our patient receives 100% oxygen to maintain the saturation above 92%. Sometimes inhaled beta agonist can be given, and this is to basically decrease the bronchoconstriction. Make sure to check the levels of CO. As for circulation, so remember that burns cause significant fluid losses and shifts. So for an adult, what we use is a Parkland's formula, which is basically the most common method to calculate fluid requirements over first 24 hours after an injury. And remember, Parkland formula is for lactate ringer solution. So the way we calculate it is 4 into weight in kg into the percentage of the burn. So for example, we have an 80 kilos man who is coming with deep burns to his chest. We know that chest from the rule of 9 is a 9% burn. So the way we calculate this is 4 into 80 into 9. So this comes across to be 2880 ml of lactated ringer. Now remember, we need to divide this into first 8 hours and next 16 hours for the first 24 hours. So if we divide it, we're going to give half of it. So we are going to give 1440 ml in first 8 hours and 1440 ml in next 16 hours. Basically the rate is 180 ml per hour and 90 ml per hour for next 16 hours. For children, Galveston rule is preferred. So the way that it is calculated is lactated ringer at 5000 ml per meter square of the total burn surface area plus 2000 ml per meter square of body surface area. What happens with deep burns is that a leather-like necrotic scar develops, which is often stiff and elastic. And sometimes this can surround an extremity or a neck and it can compress the underlying tissues, causing some compartment syndrome. So what we do in such cases to relieve the pressure is to basically make cuts in these areas. Remember, a scar is basically a dead tissue, so it does not cause much pain to the patient and it's practically bloodless. Regarding wound management, so first degree burns, because there is some local pain and swelling, so it can be managed by NSAIDs or aloe vera. Remember to clean the burn with soap and water. If there are large or tense blisters, then that can be aspirated and de-roofed, and any non-adherent necrotic material or tissue can be removed. If we are transferring the patient to a burn unit, then a non-adherent dressing must be applied. And remember to supplement the patient with antimicrobials like neomycins. Occlusive dressing can also be used because this is an alternative way of managing burn wounds. It supports a moist wound healing environment and causes less pain as it is not changed daily. Regarding the type of dressing in Rosen's, basically Mepilex is recommended, which is a silicone based foam dressing which is impregnated with silver. Regarding pain management, so we can give NSAIDs to the patient, we can give opioids to the patient, but if that is not helping to control the pain, then what has shown to have some benefit is IV ketamine in dose of 0.1 to 0.2 milligram per kg and it is noted to be as efficacious for burn patients. Finally, we'll end this topic with what is the criteria to shift a patient to a burn unit. So first of all, large burns. What do we mean by large burns? More than 20% for young adults, more than 10% for children and the elderly. Number two, if we have any deep burns, basically more than 5% full thickness burns. Number three, any high voltage burns, any chemical burns, any inhalational injury. Number four, burns over sensitive areas. So what are our sensitive areas like face, ears, joints, perineum, hands? And finally, in patients on whom we had to do sclerotomy. This brings us to the end of thermal injuries.